Hello, this is Dr. Scott MacLean, and this is a YouTube presentation about implant dentistry. During today's case, we're going to take out an upper premolar, replace it with a NobelActive implant, and then put an immediate temporary crown on. The interesting thing about this case is we're going to place the implant in a little bit of a lingual position by accident, and then save the case by placing the implant in a more ideal screw-retained position. So stay tuned and you'll see how I create this implant to really work well for me. The patient has quite a bit of missing tooth structure on the lingual, so we decide we're going to do an immediately placed implant. We'll begin the procedure by doing an atraumatic extraction using a Shea 2mm from Salvin and a mallet. We create a little area that we're going to be able to grab our elevator in this area. So we're going to use the physics forceps to rotate this tooth out and elevate it up. So the physics forceps is actually not really a forceps, it's more of an elevator type of procedure. So we take the forceps, engage it on the lingual aspect of the tooth that we've just exposed, and rotate it just slightly, just to get the ligaments kind of stretched. Once the ligaments are kind of moving, it's easy to take this tooth out. We just kind of put a regular forceps on, give it a little twist, and then out comes the tooth. And this was a quite firm tooth, so this is a great way to get the tooth out and cause very little damage to the bone that we want to save. We take a curette to kind of clean the granuloma tissue. There's none in this case, but sometimes you'll find a little bit of granuloma tissue. So we want to make sure that this is out of the area. The precision drill is my favorite drill to start the osteotomy because it is a precise drill. You can put it into the socket and try to find where you want to place the implant, and it stays on that path. In this particular case, it's a bit challenging because the two roots make you kind of deflect a little bit into the lingual. And as you kind of see in this case, I end up placing the implant slightly lingual to where I want to be. I want to kind of be in a screw-retained position, which is going to be having the screw come through the central fossa. So as we go here, we'll check with a direction indicator to check angulation. And so here's an x-ray that we take, and you can see that there's actually quite an undercut around the tooth that's on the bridge work that's right next to this indicator. Now, by leaving the indicator in place, I can put a piece of rubber dam over it and then adjust the contact. So I try to get the contact to be within 5 mm of the bone to kind of follow Tarnow's rule. And this way I'll be able to create a better papilla. It also gives me some prosthetic space in this case, but it's difficult to adjust this until we have the tooth out. So now we'll go back in with a 2.4 to 2.8 straight drill and prepare it, and then proceed. And on these successive drills, we don't want to go the whole way, from a drilling procedure. We want to kind of let the implant do a little bit of the last work. And here we are with the implant. This is a 4.3 by 13 millimeter NobelActive implant, which is pretty much my favorite implant on the planet. I find that this implant goes in and does exactly what I like to do, which is to have great stability at the time of placement. So I'm able to get this and screws in quite nicely because of the thread pattern, and it has the platform shift on top, as you can see here. But what happens is when we put this implant in, the thread pattern is such that it has a very narrow thread, which is a variable pitch, but turns into a square thread at the top. So as we put this in, we get this great stability, even though we have a socket that the implant is actually smaller than the socket itself. So I decide that I really don't like the position because I'm a little bit lingual here. So the beauty of this implant is you can take it out and give it another try. So I'm trying to redirect this implant, but I'm not really having great success. I want to be in a screw-retained position. I'm more lingual here than I want to be. So I want to be screw-retained so I can have the screw come out the access right in the central fossa of the tooth. So I go back in with the precision drill, and I'm going to do a little bit more preparation to try to redirect the apex of this implant in order to get the stability I need. So I go back in and prepare some more, and you can actually prepare along with the precision drill and the 2 mm drill. So you can actually be more than the 13 millimeters with this drill, and this will help you to redirect better. So you can actually even penetrate some of the sinus bone if you wanted to. We didn't have to do that in this case, but we're able to go back in and then redirect it a bit because this is a two-rooted tooth. being a two-rooted tooth, the tooth is actually dragging us into the lingual position. So I go back in, prepare the osteotomy one more time, and using the 2.4 to 2.8 millimeter implant straight drill, and then coming back in with the 3.0 drill. We don't drill these drills to full length because we want the implant to do that work. So you can see the thread pattern here. The thread pattern is narrow at the bottom, variable pitch, turning into a square thread as it goes up the implant. And this is what enables you to get this great stability. So now I'm in that screw retain position. You can see I'm fighting a little bit, but this implant is going to go in and do the trick. The neat thing about this is that as I'm going in, I can feel the stability kind of mounting. So you can kind of feel the gain in this torque value, that as it goes up, I'm kind of grabbing onto different parts of the bone. So here we end up having a torque of 45 Newton centimeters, which is 10 Newton centimeters above the stability I like to have when I'm placing an immediate temporary on. So here I'm happy. I've had the implant in and out and still get 45 newtons, which is pretty amazing from an implant system. Being satisfied with the torque, then I start to make my temporary, because I know that the temporary getting in here is going to preserve the soft tissues and create a better environment for healing. And actually, most times the patient has zero pain when we do it this way, because it's almost like putting a band-aid on a cut. When you put this temporary in, you're going to create an area that the air is not getting in and the inflammation stays down. So the bone actually seems to stay a bit healthier. So I start by making a little bullet so that I don't have free-flowing resin in the socket, and I'll make this bullet on the temporary cylinder that I can get from Nobel Biocare. But then I go to the mouth and start to build the facial surface so I can just reference that. So we'll like Currette, build the facial surface, build the contacts, but not really put any flowable resin down around the implant itself. It's just going down to the abutment. And once I do this, then I can do the rest of this type of procedure out of the mouth. But we want to pick up these contours of the facial plus the two contacts to the adjacent teeth prior to taking this piece back out and do all the finish work out of the mouth. The ideal temporary for singles is non-functional, so no load, working, non-working, or protrusive. So I like to make the temporary before I do any bone grafting, because we don't want this kind of getting into that area, being pushed all around. So once we get the temporary made, we'll go back and put a 5mm high straight healing abutment on to prevent graft material from going into the implant. And I can come back with some allograft bone and then graft the jump gap and place it on even on the lingual and the buccal for this particular case. But we want that bone grafting to go down inside and be engaged with some blood, so that this is going to help to fill the jump gap and keep everything happy and healthy in that area. And once the bone graft is in place, we can actually take the abutment back off, and then we're going to place our temporary crown back in. So one comes out, one goes in, and then we clean up a little bit of the bone grafting, and then we're off to the races. So we can see here that it creates a fantastic environment for healing. The bone stays, the soft tissue stays, and this implant is going to be there and service the patient for a long time. So this is Dr. Scott MacLean, and this has been a YouTube presentation about implant dentistry.